All right. Well, welcome everyone. I'm happy to welcome everyone to this seminar that's being done in collaboration with the Health Everywhere Hub and the W21C Department of Community Health Sciences and the O'Brien Institute for Public Health. So today's seminar is called From Fragmentation to Connection, Digital Health Solutions for Equitable Perinatal Support. And shortly I'll hand it over to Mary to moderate, but first I'd like to start us off by acknowledging the land that the University of Calgary is located on. The University of Calgary is located in the heart of southern Alberta, and we both acknowledge and pay tribute to the traditional and contemporary territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of Siksika, the Kainai, and the Kainai First Nation, the Tsuut'ina First Nation, the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation within Alberta, including the Nose Hill Métis District 5 and Elbow Métis District 6. On this land and in this place, we strive to learn together, walk together, and grow together in a good way. To this end, I personally am committed to educating myself and sharing my learnings with my team and trainees. In the past, I've taken the MOOC through U of A, as a lot of people have, and done considerable reading. And one of my personal favorite books is Medicine Unbundled, and welcome any additional recommendations that any of you have. More recently, and how I continue to seek opportunities to learn, is learning about the evolving 6 principles of ethical Métis research. And I've just recently registered in the training course for OCAP. So today, Dr. Mary Brindle will be moderating our session. I'm very happy to introduce her as a close colleague who I work with quite a bit. So Dr. Brindle is a distinguished pediatric surgeon and serves as the director of EQUIS, which refers to Efficiency, Quality, Innovation, and Safety research platform at Alberta Children's Hospital. In this role, she leads a chair-supported program dedicated to addressing health system issues related to pediatric surgery, fostering innovation, and ensuring safety through international and national collaborations. Dr. Brindle is at the forefront of advancing medical practices, particularly as the leader of the International Enhanced Recovery After Surgery Neonatal Abdominal Surgery Team and secretary of the International ERAS Society. Additionally, she holds key roles as the director of Safe Surgery and Safe Systems at Harvard School of Public Health and Science, and her extensive research, which has received funding from sources such as CIHR, NIH, AHRQ, is presented globally, reflecting her commitment to advancing surgical care. Thank you so much, Dr. Brindle. I could keep going.
No. This is like more
this
than
is
enough.
incredible. I'm so lucky to work with you. Thank you.
Thank you so much, Karen. So welcome everyone. Thank you so much. I've been looking forward to this event for a while. We're hoping to make this relatively informal. If people are having trouble seeing or hearing, please let us know. We can speak louder. Feel free to move up. We're going to have an opportunity for people to reflect a little bit on their experiences and ask questions. Please feel free to do that. My first job for this, which is great, is to get to introduce our 3 speakers for today. I have questions that I'm going to be asking, but please feel free to put up your hand when we are discussing them. Feel free to ask questions as well. So I'm going to start with Laura. So Laura Sandström is a Finnish midwife, and she's also a postdoctoral researcher who's working with Jenny, I will introduce shortly. And Laura's interests right now are primarily around issues of equity and quality and collaboration. So one of the areas that she's been working on, I'd love to hear a bit more about this, is developing a tool that specifically explores the fear of childbirth and promotes the fear of childbirth. And she also looks to promote integration between primary care, midwifery, and specialized services. So a lot of the work that she's been doing works at this intersection of policymakers, families, as well as the health system in which we work. So I'd love to hear a little bit about your journey and what you do and the kind of projects that you're working on.
Yeah, thank you, Mary. So nice to be here. Thank you for the invitation. I'm Laura and I'm from Finland. So I'm bringing the Finnish perspective today, offering that to you. I only arrived in Canada a week and a half ago, so I'm very new here. So I'm a registered nurse and midwife, and I've worked clinically at the hospital as a midwife. But during my PhD, I developed an intervention for women and people with fear of childbirth. And it was not a digital intervention, it was an in-person intervention with a psychiatric nurse and a midwife. And they went to the hospital 4 times during pregnancy as a group. And there was a lot of peer support, included psychoeducation, methods of CBT. And then they met after the birth. And that was the last meeting. And then I tested the feasibility of that intervention. So that was my PhD. But now I'm here to work on my postdoc with Jenny, and Jenny can tell more about our project. You also mentioned my areas of interest. In addition to that, I'm really interested in midwifery continuity of care, which we lack of in Finland at the moment. We have no continuity of care from the midwife. Then perinatal mental health, because fear of childbirth. I will continue with that. Women-centered care, and then I'm really interested in different types of the non-conventional ways of giving birth, so free birth and home birth, which are a rising phenomena in Finland and globally as well.
Yeah. Thank you so much. And I appreciate the fact that you've highlighted that innovation does not necessarily need to be linked to technology. And there are many, many health systems innovations that can take advantage of it, but don't necessarily need to be based in that. Jenny Auxier, thank you so much for joining us from BC. So Jenny heads the Parent Engagement Lab at the School of Nursing at UBC. Her research aims to integrate the elements of parent engagement into kind of all aspects of perinatal digital health service innovation development. And so this goes all the way from development through design, through quality assurance. And with this, she aims to basically work with families and meet them kind of where they're at. So in this environment where we have an increasing expansion of digital health opportunities, families come to the table and bring their own needs and expectations and experiences, and sort of understanding how you work with that to create digital innovation is one of the areas that Jenny has been developing. So within this, of course, there is also many of these aspects of collaboration and working across different teams, and I'm expecting we're going to hear a fair bit of that today. And also one of the areas, and I should also mention that Jenny, although she's from Vancouver now, has also spent time in the Netherlands and Finland, so we're going to get a lot of different perspectives on health systems today. She also has an interest in culturally secure access and exploring the issues of access specifically for racialized groups. So Jenny, would love to hear a little bit more about your work.
Thank you. Well, that was really comprehensive. Thank you so much for all that background bringing forward today to give you guys a peek into what I'm up to. I would say what's the most relevant piece of information before we get started chatting is that my program of research has begun a year and a half ago at the School of Nursing at UBC, and I'm the only assistant professor or professor studying perinatal in the intersection with digital health in the way that I approach it through a sociology lens, but also having a wealth of experience working with medical practitioners, human-computer interactionists, specialists, computer scientists, and engineers. So come up and ask more questions about all these different fields of science I'm mentioning, but I find I can't do my work and find my interpretative power and looking at my results without accessing the expertise of others. So I'm grounded in nursing science, but I'm interested to build something new inside our department at UBC, and bringing someone with Laura's expertise from international perspective on how parents experience perinatal care is a great way to practice and build the muscles of interdisciplinary and international as well as national work. So see that's a bigger umbrella about the work I do, and I think that's it. Yeah.
That's
awesome. To your comprehensive description.
That's wonderful. Third speaker for today is Dr. Tito Daudu. Tito, I will be like transparent, longtime friend and colleague. She is a pediatric surgeon at Alberta Children's Hospital and assistant professor in surgery and community health. She comes at this obviously from a different perspective, not being someone with the perinatology, maternal health background, comes as a pediatric surgeon, but we obviously have many of the same shared interests, and she is someone who does a lot of our maternal fetal counseling. So there's an opportunity, I think, to reflect a little bit of a different perspective. Tito was born in Nigeria and raised in Winnipeg, and she got her MD in Manitoba and then completed her surgical training here with us in Calgary. She obviously brings a very, very rich knowledge base to her work, both from her own personal experience, but she's also got her MPH from Harvard School of Public Health and also did a certificate in global health surgical care from UBC. She's an award-winning researcher and educator and focuses on health equity, anti-racism, and improving access to surgical care for underserved populations. She's received over $1 million of grant funding from government agencies and other sources, and really explores a lot on how geography and systemic barriers affect the surgical outcomes of our patients. She's a recognized voice on racism in medicine, as well as inclusive leadership and equity-driven health and policy. So thank you, all three of you, for joining today. And I'm going to get us started off with a question here. We'll take a pause as we go and see if there's questions from the audience. But Lauren, I'm going to start with you. When families say that perinatal care appears fragmented, what does that mean? What does that look like for the people in the system? How does that fragmentation present itself? And are there places where you feel like that's being addressed particularly well?
Yeah, thanks for the great question. It can look different for different kind of families, but what comes into my mind, it could be, for example, that you don't have the continuity of the carer, of the professional. So as people, we are one whole. So we can't extract like our problems to be handled with one professional and the other one. So you have one problem, you go to one professional, and then with the other problem, you go to the other professional. And that's really burdensome for these families. And it might even cause them to not know who to contact, when to contact, where to contact these professionals. And it might cause that they don't get care in a good time, or they get care or like missed care, so they don't get care enough. Or it might even be that they get like double the care from different professionals, and that's not efficient. That's not good way for the health system to work. It's not cost effective. But what it means for how the families can see it, it means that they have to repeat information. If the information is not going from professional or from system to another, so they have to repeat it over and over again. And that's a lot of work for many. And some might say, I give up. I don't want to do this anymore. And then they don't get the care that they need in the right time. It also might cause them emotional stress, and they might be really frustrated that they don't get the care that they need because they don't know who to contact, for example. And in Finland, what we're seeing, it causes distrust in professionals. So they don't trust the professionals or the system because they don't get the care that they would be needing. And I know that the Canadian healthcare system is different for perinatal families than in Finland. I've learned that now in the week and a half I've been here, but maybe I can share the Finnish system. Yeah. So in Finland, we have public healthcare that covers everybody, all residents in Finland. And when you get pregnant, it's free of charge to all families. So we have statistics that these families, perinatal families, 99.8% of them use these services. So that's quite good coverage.
Yes.
And what that means, when you get pregnant, you go to the primary health care, and there's a public health nurse that takes care of you during pregnancy. And at the same clinic, it's team-based. So whether you need a psychologist, whether you need physiotherapy during pregnancy, whether you need the doctor, a nurse, anybody can access that in the same health facility. And the public health nurse is the one who coordinates your care. So you don't have to do anything. She tells you, hey, I got this time for the dietitian. It's next week at 3. Just come here and go sort everything out. And then the same public health nurse, you see them, you have regular checkups during pregnancy. And then after you give birth and you get discharged from the hospital, you go back to the same public health nurse. And she will take care of this family until the child turns 7 years old. And then after that, that's the continuity of the care. And then after the child turns 7, they go to the school nurse and then they get regular checkups there. The only fragmentation that is happening is during birth. So during pregnancy, you go to primary care, same continuity of care with public health nurse. But then when you go and give birth, you will not know who's there. You don't have the same midwife. We work in 3 shifts. So if you have a long birth, you might see multiple midwives and obstetricians. And then when you go to the postpartum ward, it's a different midwife, different doctors. So that's where the problem lies, in my opinion, at the moment in Finland. But otherwise, the system works pretty well, and it's all free of charge.
Wow.
Yeah.
We could learn a lot from girls. That is an incredible system. And one of the things I'm gonna ask you, Jenny, your thoughts about this, but as you were talking, it made me reflect a little bit on some of the issues that we have, and our group talks a lot about this. When you have people who receive care in different sites from different clinicians, we rely a lot on electronic medical records. And one of the areas where we find challenges are that we don't actually have one digital system that captures all that data. How does Finland handle that?
Yeah, we have one digital system. So when you go to primary care, all that information goes to specialized care, to the hospital. So we see everything that has been done. We also have access to the social care, what there's like a need for that. And then all of the information from the specialized care, so from the hospital, if you go there, you need a checkup with the doctor. The public health nurse will see all your diagnosis, what has happened, what they talked about, and even going from like another city to like wherever in Finland, they can access that information. So that's also the burden of the family to having to repeat information or being the expert of their own diagnosis or medication or care, because it's the professionals, the information moves between different levels and different systems, and also to pharmacies, for example. So if you get a prescription for medication, you just have your social insurance card and you can go to any pharmacy and get the medication you were subscribed.
Wow.
Well,
Yeah.
Well, I don't.
yeah, how do you follow that?
I'd love to hear a bit about what, maybe what the Canadian experience would be like, or a little bit on how you see this fragmentation in the system, or how our patients see this.
Yeah, and our parents, that's what we would call them in our
parent patients.
Parents.
Yeah.
So fragmentation means, to the parents that I've been in communication with, we've been doing some community engagement work, and we do this work that is pre-ethics engagement, where we're meeting with folks and hearing about how they're experiencing care before we run into research protocols. We're building trust and relationships. So through that work, I can share a little bit that the parents we've spoken to in the local communities, specifically voluntary long-term immigrants, is where we've been having some discussions. And if you want some help understanding that term a little bit, I could break it down at some point. Basically, parents move with the flow and bend to the institution. They encounter care, and quite often, if they want to move forward with the professionals, they follow suit, they find the dominant culture, they find the mainstream space, and they do their best to move and bend in that direction. That is the whole person Laura just talked about, that a parent experiences. Their whole person is almost hidden in a shadow when they're having these interactions. And so concrete examples of that would be that family experiences the birth of a newborn, and that newborn needs to be admitted to the neonatal intensive care unit, and there's a certain level of care that that newborn requires, and we're in a particular hospital, we're in the right place, we start our care process here, and then all of a sudden the care starts to change, the newborn gets well, but it's a stressful experience for the parent. And the healthcare professionals say, you know what, the level of care you're at, you actually need to change the hospital. We're going to move you.
Mhm.
And we understand why that's happening for all sorts of structural issues. And I'm not saying that they can just fix this, but then the parents are bending, the parents are moving and flowing with the system. They don't have much choice to change that. But there are so many reasons why a parent would find that difficult, and why it also disrupts their process for, well, here is a double word, but processing the trauma they might have experienced. To have a newborn that is now going to be admitted to the NICU. I think maybe the parents experience this and there isn't a lot of trauma, but I can't imagine a case in where there isn't just even small t or big T trauma. There's a variety, and there's usually some disruption to feelings of safety when this happens. So just as a little bit example, that's what I think fragmentation looks like for some parents, and especially those who are not naturally fitting in a dominant culture or mainstream culture, especially. And then where are we doing this well? Where are places where this is getting solved or looked at? I think the fact that, let's speak to nursing, and then I want to learn from other colleagues in interdisciplinary thought. But from nursing in Canada, the undergraduate nursing degrees and registered nurses are trained to understand something called family-centered care. And we even go as far to get into the details and weeds and the different versions of family-centered care, family integrated care, which some of you might be quite familiar with. It was sort of birthed here in Alberta, so Alberta Phi Care. And so we have set up these models to be part of the theory that we train our undergrad nursing students. So they're exposed. So I think that's where we're getting to the heart of it. And if you can follow my train of thought, the family-centered care is meant to involve the parent and look at the parent as part of our care when we're treating neonates, babies, newborns. However, once you enter the mainstream institution work in acute care, the capacity for that theory to move into practice is where. So it's a kind of a bad news story in the sense, where are we doing this well? I'm saying we started, and I don't think we really opened it up and acted on it. And there's institutional reasons why that's not happening. And then finally, I would say the only other place I'm, in my mind, where I'm expert in is that our team of researchers at UBC School of Nursing, the Parent Health Engagement Lab, we are working to understand and stop fragmentation of care. But we have to start from square one. So we're making a start, but we're not very far yet. But we have a vision and we know where we want to be. And that's parent driving the work, but we'll get into that.
Now, as you were talking, Tito, it made me think a little bit about when we see a neonate who comes to us shortly after birth and the mother is at one hospital and cannot leave because they have had a C-section or what have you, then the baby comes to our hospital and needs an operation, like urgently. And that to me seems like, such a huge, example of this fragmentation. I know that I just gonna drop this on you, but do you have any sort of reflections on what that looks like when we're having these babies sort of sent across the city and shortly after birth?
Yeah, we have these in situations that are planned where, and doing a lot of prenatal consults with parents who have babies that have been diagnosed with congenital anomaly. There's no amount of planning that can actually prepare you for what happens when you birth a child and they're taken from you, and they're not just taken from you down the hall, they're taken from you to an entirely different center. And there's maybe a lot of preparation that some of those parents and families have for that situation where they've been told this is what's going to happen and what needs to happen. But a lot of the time we find ourselves, as you know, in situations where it wasn't known. And suddenly you have a situation where a kid was born on the other side of the city or in a different city entirely. And the only place that the baby can get treatment is Alberta Children's Hospital. And the parent, is somewhere else. Maybe there's one parent that is with them in the NICU. There's other children that are at home. And I think it really gets to what you're talking about, that centering the entirety of the family. Because as healthcare workers, as physicians, surgeons, we're often very focused on, well, we need to get this care for this baby. They need to get taken care of. And we forget, well, there's a mom who's healing who can't pick her baby up because she had a C-section, and they have 3 kids at home and they live 3 hours away from the children's hospital. They don't have a community here of people that can take care of them. And I think, we're getting better at doing that when we're prepared. But we're so often unprepared and we haven't considered the variables. And we'll get into it more and more in terms of as this conversation goes on. But I think one of the things that we are learning to do better is actually talk to families about what their needs are, and instead of assuming what their needs might be. Because, we're so used to saying, oh, well, I imagine what it might be for you to have 3 kids at home 3 hours away. And here are some things that I might offer. But I think that when you start talking to parents, you start talking to families about what their true needs are, where they're feeling those pressure and stress points, becomes really quite different. And I think we're improving, but our systems are truly not set up to be able to accommodate it at this point.
One of the things, an incredibly meaningful discussion that I had with a mother once, it was after her child had been discharged from hospital. And I remember her saying that she felt she got cheated out of the experience of being a parent because it didn't go the way she was expecting. Her child was sick and needed to be taken away. And that all of the things that she had planned for in being a parent, she lost those things. And the system doesn't always recognize those elements of the patient experience, the parent experience. So I'm going to go to another question. Jen, I'm going to ask you this question first. Is there a particular moment in this perinatal journey where you feel, and this may be like a Canada-specific thing, but perhaps not, it might be different, and so I'm interested in your thoughts as well, Laura, but is there one specific area where you feel there is the greatest opportunity for a digital solution, like some kind of technology-based solution? And what would it look like?
Thank you for the question. Everybody's curious about this. What's the next latest and greatest? And AI work and digital health innovation is the hype, right? And I don't know if it's the answer to all of our questions, all of our fragmentation, but with the experts I work at, I stay cautious and excited at once. So I am excited about perinatal mental health supports and tracking that can happen in day-to-day circumstances, real time, tracking that parents feel comfortable and safe interacting to show their own practices and experiences so they can learn how to observe their own symptoms and share that with healthcare providers. So if I can break that down to practicality, that means that there might be a protected AI system in which we all have, I think everyone is thinking about large language models. And if we have one that's secure within an organization that's moderated, and the parent can have this AI language model become a companion and helping them track and monitor and look for patterns, there's potential for parents to become these experts in observing themselves with the help of technology. Now, the thing I'm excited about with that is that parents often are surrounded by a structure where they don't feel like sharing all of this detail. And they would also like to understand their symptoms before they go and show someone. And when you're in the NICU and maybe you don't fit the mainstream culture and you have your own values and beliefs about what is good care for your baby, and you're having mental health disturbances, how open do you feel to share with those social worker at the bedside? Some might feel open. Some might have had a really great social worker interaction, a nurse interaction, a doctor interaction, and they're open and they share what they're experiencing about anxiety. But parents could feel quite threatened that they are supposed to be a parent. So they have to be ready. They have to have capacity. So what I'm speaking about is if you can share with an AI system that's safe and protected and parents feel that neutral partner, but that takes work and examining how parents are going to take up that. We have had examples in the literature. I would say from the wealthy part of the world, I've done a scoping review and where we looked at there's 4 segments. We have the low middle income and the high income. So when we look at the high income countries, how parents have sort of described their experience with connecting with digital services during perinatal periods, is that the AI was the only one who asked me how I was every day. Oh, I had somewhere to lean on. So you get this hint that there's a companion possibility there, but we have to investigate it, find out if it's safe, find out how parents will take it up. And we have to be understanding that we have to know that it's transparent in its design behind the scenes and know all the working parts so that it's ethical and sustainable as well. So I think for perinatal, this includes wearable devices that are attached into these AI systems as well. So this is how you can monitor daily life. I give you that sneak peek. There's more, and perhaps we get there with the next bit of questions. But I think the biggest risk is where parents are not being supported with preventative services with their mental health support, and the biggest opportunity is this kind of looking at daily life of parents, when they're open to it. If they're open to it.
Yeah.
And I will also just say one more thing, whether they're open to it or not, we're being inundated with this kind of monitoring. So if we can harness it and teach parents about how to use it in a safe and comfortable way, then I think we're doing them a great service, because they're actually bombarded with it. And when we were speaking this morning about the population who might be considering getting pregnant, maybe they're between 20 and 25, or maybe we're a little bit later, but that group is so busy with the technology, and they don't always know what's coming at them and what they're interacting with. So if we can give them information and support with the usage, I think it's a good opportunity.
Yeah. It's such a good point, because I feel like, in our personal lives, people are using digital health tools all the time. I think that is way more advanced in our personal lives than it is in our medical lives. So I don't know if you had any other sort of perspectives, and whether it's kind of a similar sort of need that you might see in a place like Finland or other places. I'd love to get your thoughts.
I agree with Jenny. Mental health is something that we can I see that as an opportunity for digital tools, and also the next generation. They're so used to using their mobile phone, wearable devices. They've been brought up with technology. So I think they might be also more open to using and trying these kind of digital tools out, and they'd be comfortable in using them. But what I think are the opportunities, biggest opportunities are at transition phases, and if there's gaps in care. There we could use digital tools to try and make the gaps smaller and help the transitions. For example, in Finland, the immediate postpartum. So when you get discharged from hospital with your baby and you're going home, at least if you're a first-time parent, might be, even if everything has gone normally and everything has gone well, it might be a bit exciting to go home with the baby and all of the feeding. If you're trying to breastfeed, it usually, well, if you read about it, it's like you just take the baby and everything goes fine. It doesn't go like that.
Yeah.
You need a lot of help in the beginning. It might be the first few days, it might be the first few weeks, the first months. So I think that is one a part of care in Finland that there's a gap there. So when the baby is born, the focus shifts from the pregnancy to the baby. We kind of forget the one who has given birth, the woman or the birthing person, and they're left alone.
Right.
And what about the father or the companion? What about them? What kind of feelings are they having? How can they support their own spouse and helping out with, daily chores and helping out with breastfeeding? So I think there's the gap, and that's an opportunity for some kind of, I don't know what the digital tool would look like, but maybe it could have some information like education. You could it could have a chat. So, or you could take pictures, maybe like video conference calls with the public health nurse or the midwife at the birthing hospital. There's a lot of because there's fragmentation during birth. So if you had a bad birth experience or even a traumatic birth experience, it would be really good to catch up after that when you go home and you start processing it. And maybe this digital tool could help you connect with the midwife who was there when you gave birth, and you could have a discussion with them. what happened, why it happened, and that could already be a really good intervention for them. And also the breastfeeding, but this I could see as a good opportunity. The transition from hospital to home, they might be feeling left alone without proper knowledge, education, help, care, and that could be something to look into.
Thank you. And then I'm glad that you mentioned these sort of gaps in care, because I feel like we encounter these in all of the aspects of healthcare that we deal with. And Tito, I had a question I wanted to ask you about that, because I think there are certain populations that feel these gaps more strongly. And I think many immigrants and marginalized patients do a lot of extra work to access care. And I wondered if you could, Tito, describe a little bit on what are the things that lead to this, and are there opportunities for digital tools, to help those, or are there things that we have to worry about if we're thinking about using digital tools to address?
Yeah, I think that's a great question, Mary, because, we really think about where these gaps lie. For any gap that we can identify for, the dominant culture, the dominant population, those gaps often are exacerbated in folks who come from equity deserving backgrounds of any sorts. And we see this a lot in the work that we do and with the families that we work with, that there are so many additional barriers that both things that we know and things we don't know that are going on for these parents, the families that can be operating, that can add, an extra burden. So, there's things that may be a little bit obvious, like a language barrier, but a language barrier is more than just, the difficulty communicating and a difficulty in, or, requiring a translator to go through all of the things that are happening. We also have to recognize that language barriers might also represent differences in medical literacy. It might represent, or not, but we often treat them in the same way because we have an assumption. There's lots of studies that show that when you're using a translator, we tend to actually use worse language and less when you're compared to, you're talking English to your translator. And if you were to speak to somebody who is another native English speaker, the way that you explain it, you try to use easy, clear terms to understand. And there's lots of studies that show when we do that with a translator, we're more likely to throw in medical lingo. We're more likely to make it more complicated, which means it's harder for the parents to be able to understand when they're getting it through a translator, because we think that the translator is doing that part of the job for us. And so there's different layers to that are gaps in how much our patients are understanding. And when we start to think about these digital health solutions, a lot of the time they assume a level of literacy understanding, and that's for anybody in the population that we may not be able to assume. Often these large language models are being done in English or maybe French or maybe Spanish, all of these languages that are, spoken by, European European countries, and that may not be, those languages may not be accessible. The translation of AI, which many of us have come to rely on, is not always accurate. And so some of these gaps, I think, are things that we need to be really careful of. We also have to be careful about our assumptions about what access people have. I think that it's really easy to say, well, everybody's on a smartphone. Everybody should be able to access an app or download this or type that. And the reality is that the way that our society is structured and the people that we have, that's not always the case. People don't always have regular internet access. People don't have necessarily access to a phone. There's many families that we see that have one phone that's shared between the entire family. And so we have to really think about those things before we make assumptions around, oh, well, this is increasing access. Sometimes we're actually adding to that fragmentation because suddenly we've created a digital solution that we think should be easier for everybody to access, but that's now made it more challenging for somebody to access because they don't have the same access to those kinds of technologies. And the way that we build it, the language that we build it with, even the visuals that we use in that language, all of those things can add to how safe people feel in using that technology. Racialized people are very used to seeing all of the pictures and examples are of white or European background individuals and so they don't necessarily know what that might look like in themselves. What does bruising look like in somebody who has darker colored skin? All of those pieces need to also be considered, I think, when you're building out these digital health solutions so that people can also see themselves in it and that can add to that level of safety.
Thank you. And Jen, I think you had some reflections on that as well.
Yeah, you can tell when I'm thinking.
Yeah.
Thank you so
Yes.
much for all of
Yeah.
these points. And one of the things that came to mind is that we are working, when I said parent driven, we have a little bit more with the specific questions to get into it. But one of the things Laura and I and the team will be working on is through consultation with community workers on the ground who are working with immigrant families in our local communities. We have found out that a really good approach to starting to understand parents' practices and letting them input something so meaningful into our design cycle for digital intervention is that we have a meeting where multiple languages are actually going to be occurring. Our English speaking work is very structured, clear, consulted with the other members, and then our community partners will be translating into the various groups, and then we get back information using something called cultural technology probes. It's a little complicated when it comes to technical, but we're getting from the parents their exact reflection, and in they consult basically to us. You have designed this intervention, it's a dream, and we got a picture of that dream. Here's what we think about it in our own language. And this is the way we have to go. If it's really parent driven, we have to be doing it like this. So we have yet to get those running, but that's our conception for the next steps, to begin these right from scratch. And this is so great, thinking about how visuals are important and taking a mirror of their own life and experience and reflecting it back to our intervention plan, which as academics we can think is also clever. But we will have humility with that and pull it apart, design it with the intention of incorporating the culturally relevant details. So that's what got me thinking about. That's a dream. We hope it happens.
And one of the things I was thinking, and Tito, it made me think a little bit of the work that Tia Marchand, who's one of our Indigenous scholars, has been doing, where we have these ideas sometimes of where does primary care happen, where does acute care happen. We have a huge problem with access to good primary care right now. And many of the Indigenous patients that interact with the system receive their primary care in the emergency department. And there is understandably a push back against that idea that primary care is delivered in the emergency department. Nevertheless, it is a critically important space where healthcare is delivered. And I feel like sometimes when we think about these barriers to access, Tia, who's a great, brilliant student of ours, basically was starting to sort of dig into that and think about that.
Yeah. And I think that just like you said, if you're not listening to, what a lot of the time with research, and this is something that I'm learning daily, is that it's so easy for us to have an idea or conceptualize this might be something great. When you take it back to the group or the people that it's intended to help, they're like, I don't know, like zero interest in that, actually. That sounds really maybe cool for you, but it's not something that we want. And I think it's Jack's part that is so important in that co-design and co-creation with the patients that we're working with, populations that we're working with, is that there's any amount of work that you can do, think, conceptualize, get grants for, work on, publish on, and it might have absolutely no real tangible impact on the population that you have, with all great intentions, decided to work with, because you did not include people from the initial design, the initial conception phase, and carry them through the entire process, because those are checks and balances in our research that are so important. And so a lot of this work that we've been doing with Indigenous communities, where we think, well, this is our grand scheme, and we're told, no, I have no interest in that at all. Okay, so now we have to start and find out what is your question, and where are the places where your questions, what are the things that we can help you to do to answer those questions? What are the gaps that you are experiencing that we can try to help to fill? And And so that's a really great point that you bring up too about the language.
Now, I have some more questions, but I'd love to open it up at this point to the audience. I mean, obviously, we've got these great speakers, great perspectives, and I'd love for people to be able to, ask some questions if you've got any, or even share some of your own reflections about what we've been talking about. Any questions, thoughts, reflections from the group?
I have it's not really a question, I guess, it's for a pro.
That's
But-
fine.
So I'm gonna pick on something Laura said was around distrust because of this fragmentation, right? Having to constantly repeat each themselves and that distrust builds. So I work with Mary and Tito in the surgery world, but my primary focus is on head and neck cancer, most of which have surgery. Very different patient population than you're talking about. You're the same thing, right? Like this kind of transcends. So I guess I have to frame it in a question, like how do we navigate that? How do you consider that? And also sometimes people have distrust in digital and health solutions too. So how do you navigate this distrust? Sorry, it's not a great question. It's just more of
It's an excellent question. Difficult to answer, but I'll try. I think the continuity is really important, and also for the patient in an ideal world, like in the prenatal context. The ideal world, the parents and the family would be able to choose their own midwife or public health nurse. So they would, get to know each other. Do we share the same values, and do we share the same type of way of seeing the world, and what kind of care I want to get from you? That would be the ideal thing. And that way, through continuity, you would build the trust. Because what's happening in Finland, when I said distrust, there's the fragmentation during birth, and that we have a lot of bad birth experiences and traumatic birth experiences, and that is causing mistrust or distrust in midwives and hospitals and professionals, and that is leading to free birth and home birth, and home birth is not covered by the government. So if you want to have a home birth in Finland, you have to pay out of pocket, and it's really expensive, and so it's not available to everybody. And also the midwives who work in home birth, they are private midwives. So there's a very interesting scene going on there. They're not all of them are actually midwives. They call themselves traditional midwives, so they might not even have an education. And that's where it gets risky, because if they're not licensed midwives, they're not responsible of what happens to the family. So I think continuity is one way of trying to help the families trust the professionals and the system better.
Is it okay if I take a stab to add? So pulling on threads that you had, thank you for explaining those pieces in the perinatal world. I've had a general nursing experience and background before I went into perinatal specialty, so I can envision. And I think maybe many in the room, we encounter a family member who's been experiencing care in our Canadian system. So I come with those lived experience and nursing professional experience, tying into the research objectives for our work, to answer your question, your great question. So here it is, and as I give a big description of how I will answer it. So the continuity of care, trust building with the professionals, needs to help us build certainty and familiarity in the system. When the public encounters the system, there should be things that feel easy. I know where I am, I know who's here. And I know that I might not know everything. I know there's uncertainty, but this person gives me some predictability, and the technology we use together is also somehow predictable. And so the way that I envision that happening on a grand scale is to start the model I developed in my PhD to guide patient engagement as we design could be used outside of perinatal care, but it's just not ready yet. But let's do it, right? And so basically starting from the beginning, not getting too much work done ahead of time in the conceptualization of our interventions before we let the patients drive the process. And so in context, of care that's surgical and fairly routine from the healthcare provider. I'm assuming when you talk about head and neck surgery, we have some consistency in care pathways, predictability in that work, similar to orthopedic surgery, for example, where you have some hip and knee surgeries which are predictable. When you feed a patient engagement design process into simple places to start, I think it's a great place to start and expand our understanding of how trust can be built when the patient drove the intervention to begin, drove the design to begin with. But that has to be transparent and known to the public as well. Like, this was made for you, by you, and we include you. So that's what I hope. But that, again, that's a bit dream language, but this is possible. So thank you. Yes.
Maybe building on this, I started to think about this, right, in your talk, but I'm wondering about the role of consent, because it's actually, you were talking about the predictability, not that like head and neck cancer is predictable necessarily, but often you're going for surgery for head and neck cancer, for example, in the birthing process, a significant amount of it is like out of your control completely, and especially for like people that have their baby taken over to the NICU, for example, you lose the ability to provide a lot of consent about what happens to your baby, what happens to your body. How does that come up in your research and impacts trust and all those types of things?
You're excited to answer. Okay.
I am.
Both
Really
answer.
good. And you
as well.
Yeah. Informed consent is a big, it's a big thing that if you don't give informed consent, it might be even considered obstetric violence during birth, which is a concept that is used a lot in Finland at the moment. I think through the continuity of care, it's a very midwife way of thinking. It's almost like a philosophy. It's holistic care. So you're a midwife, you get empowered, you're in control. And through that continuity, the midwife knows you. So the midwife is more like a companion, not like a professional who is telling you what to do, but they are like giving you information, and then you make your informed decision what you want to do about that. You can take this decision, or you can take this one, and then the midwife has to, do what you tell. And if not, then it might cause these situations of distrust, and then it might go as far as not even going to healthcare at all, because you're afraid that people will do something to you without giving consent. And that's a really good question. But I think through continuity, and because there's also this concept of women-centered care, I don't know if you're familiar with that, but like the consequences of women-centered care are informed decision-making, and that supports the woman or the person navigating also these complex health systems, and it causes or the outcomes are improved health outcomes. And we do have research in that midwifery continuity of care, it is the best way of giving care to pregnant, birthing, and postpartum people, because it has the best outcomes for both the birthing person and the neonates, but it also is a psychologically safe way of offering care.
Yeah, I mean, I obviously think about consent, maybe not obviously, but I do think about consent a lot in my life and in my practice, because, so often, and in a birthing situation, this could be the case, and doing a surgery for anybody, this could be the case where, there's a big chasm between being able to have a lot of structured time to have conversations around what might occur and what things are, and when this is an emergency situation and a decision needs to be made. And when you're, in the practice of that, it's really challenging. I think what you said about building trust and having relationships is so important, because sometimes, much of the time, you have to rely on that trust, because there is absolutely no time to explain all of the things. And then we also recognize that, particularly folks that are coming from equity deserving backgrounds, they often feel like they have no choice but to say yes, because they have fears around that. They don't necessarily want to probe. And even the fact that they're presenting for healthcare can be really, really challenging for them. They're already placing themselves in a situation where they don't necessarily have the most trust. And so it's about figuring out those ways that we can structure our systems to give our patients power, taking the pauses that we can take. I think that a lot of the time we think, oh, this is an emergency and this is what we have to do. Let's go and do it. I think about, I'll just tell you a personal story is that when my mom came here and gave birth to my sister, she was pregnant when we arrived in Canada, and my sister was breech and she needed a C-section. And this is an African mom who's got lots of different preconceptions about what a C-section means, has lots of stories in her mind and all of these things that were like, you can never do this because that's the end of you, that's the end of your child, from experiences that she's had, from friends that she's had. And my mom, she's told me this story a million times, but the doctor called her obstetrician in Nigeria, who she trusted, made an international call from the hospital, and got my mom's obstetrician / uncle on the phone, who said to her, Penny, you have to do this. You're in Canada, you're safe, and you're going to be okay, but this is the only choice. And that was what allowed her to feel like, yes, this is the right decision, but she refused to get a C-section. And I just think about that as a moment where this is an emergency. It's important. You do need to get this, and that was the right decision. But the fact that somebody took that extra amount of time where we know that those gaps exist and made it so that she could feel comfortable, that she felt empowered making that decision, that is a really big deal. And I think so often we don't do those things. And, I think about that story all the time when I'm in my own practice and I'm trying to rush somebody off. I'm like, is there a moment where I can pause and make this optimized for them? Is there somebody that I can call that can bring that in? And I think that, as we build research around this, it's understanding that like our patients' lived experience is also the same thing as expertise. Like they have expertise in the experiences that they've had. Bringing those pieces in as we construct what our systems look like is so important.
Absolutely love where we've got to. Oh, please, yes.
So maybe I'll just start by introducing myself, because in this new health system that we have in Alberta, we now have a provincial program for women's health and for children's health. And so I'm Lena Jorgensen and I lead the Women's Health Alberta provincial program, and Shannon Nerfold is the lead for the Children's Health Alberta program. And of course, we're very tied together. We're very excited to be here. But my question is maybe focused a little bit towards Laura, and others may have thoughts as well, and it's related to kind of fragmentation across providers and kind of in that transition of care, for example, as things may escalate and there's a handover from midwifery to the obstetrician, or maybe the handover of a community first that ends up in the acute care setting. Any thoughts around that fragmentation? Because there's a bit of a boiling point in Alberta around that as well.
Okay, thanks for your question. We don't have community births, so they all happen in you call them acute care settings, so in the hospital, unless you have like home birth. And then between the midwife, I think how birth is cared for here is different than in Finland. So me as a midwife, I would be responsible for the family and for the birthing person that comes in. And if nothing goes wrong, I will take care of the birth from start to finish. But then, of course, if I see some risks or I have to consult the obstetrician, then the obstetrician comes in and we work as a team from start to finish. So I don't hand over the patient or so to say, it's more like we come into the birthing suite together, and if we have to go to the operating rooms, they have to have a C-section, we go there together, and then we debrief the birth also together with the family at the postpartum ward. So I think that works quite well. The problem is when the shifts change, then there's the fragmentation. You have a whole new midwife. Of course, we share the information, what has happened and where we're at now and what we think is happening to the next shift, who comes and takes over. But there's the fragmentation that is not optimal for the family, of course, because they have to make a new relationship whilst being maybe having really painful contractions and maybe being a bit scared and anxious about what's going to happen. Then they have a whole new person coming in with a different kind of energy. And that's one thing that's not working optimally in Finland right now. But then if you said community births, I could change that to these home births. So if everything doesn't go well at home, and then you have to be transferred to the hospital during birth, there we have a big problem because we have a lot of maybe it's prejudice from the hospital midwives to these home birth midwives, and they're not always treated nicely. These women and these families, these people who come to the hospital, they might be judged based on why did you take this risk? This is not good for you. You're not a good mother. You're not taking care of your baby. And there, I have heard that the social worker has come in because of a home birth, a planned home birth with a midwife, because the doctor thinks that this is the woman is taking risks for, like, she thinks this is the best way of giving birth, but it's not good for the baby. And then the doctor is taking social work into there, and then these home birth families are stigmatized, and that even creates a bigger barrier for them to go to the hospital, which might end up in a poor outcome at home.
And I would tag onto this, the thoughts that have been going here. I can pull one thread out and tying into your question about connecting healthcare providers with the right information at the right time is so vital, and the technology that we need to do that can be harnessed. And we have it so simple, just a telephone, but an international call to your mother's story. And shared decision making is core in the model that the research model that we use in our nursing research, and bringing it, understanding who the members of the team are, and having flexibility to name that team as it must be for this particular family. I think that's where we have to start in our structure design, maternal and child systems coordination that you're both busy doing. I think you can ask yourself questions. What is our institution doing that's also based on our colonial system that has stopped us from finding out who's the team here? And where is our mismatch in values going to lead? You have a risk here to pay attention to what Laura has said. When those barriers come up, because now the trust is completely broken, I don't feel respected in that space because I've been told that I'm not a good parent because I didn't do it the way the mainstream system expected. And so we can pull that thread in the unique experience that's going on in Finland for some parents, and we have that coming up in pockets around our country in different ways. And so connecting the teams with technology, we have more than a telephone now. We have some pretty exciting things, AI training AI to teach us about the structures in our institutions. And I can give you more detail one-on-one about that, but that's the work we're starting to dive into, not just a chatbot to give us a companion or predictive information. We have ways that AI can tell us about our systems and then feed us the exact relevant information about that client's team. I think that's it to say. Yeah.
Unfortunately, it feels like I had more questions. And I was really enjoying everything I've learned today from the three of you, and certainly from the questions from the audience. I would like to thank all three of you for really insightful and inspiring comments today. And I've certainly had a lot to think about. And I suspect many people in this room are going to leave this with a lot of new ideas. So I'd like to take this time to thank our three speakers today. So thank you, Jen. And please feel free, approach our speakers, feel free to ask questions. It was a huge honor to be able to chair this today.
Thank you. Yes, Dr. Mary.